All right, welcome to the Long COVID and Post-Infectious Syndrome ECHO, a collaborative effort between the University of Utah and Bateman Horne Center. If you're joining us for the first time, we're happy to have you here. And if you're returning, welcome back after the break we just had. I'm Clayton Powers, a full-time physical therapist at University of Utah and also education liaison for Bateman Horne Center. And I'm joined by Annie Romano, education coordinator at University of Utah. Today's session is being recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. And after the session, Annie will email you all with CME instructions and a copy of the slide deck. Please note that CME credit must be claimed by midnight tonight via the call-in option, and it may take up to 24 hours to appear on your CME profile. We want you to introduce yourself in the chat and contribute with any questions or comments if you feel comfortable doing so. We want it to be a lively discussion. So I have the privilege of introducing Katie Wolf as our presenter today. Katie and I have worked together for several years, and she's a phenomenal doctor of physical therapy. And actually, she'll be winning the PT of the Year award for the state of Utah later this month. Katie earned her undergraduate degree in exercise sports science with a minor in mathematics from BYU Hawaii in 2007. She went on to receive her doctorate of physical therapy in 2010 from Eastern Washington University. In 2020, she achieved her advanced pelvic rehabilitation practitioner certification. Katie's professional journey began in orthopedic acute care, where she spent 5 years before transitioning to orthopedic and pelvic health PT in 2015. She founded the pelvic health team at South Jordan Health Center, successfully growing the team to over 7 providers, and then helped to grow multiple other pelvic health programs at the University of Utah. Currently, Katie serves as the quality consultant for the Department of Orthopedics, Department of Surgery, and Department of Otolaryngology at University of Utah Health. And Katie's dedication to pelvic health, quality improvement, and the advancement of physical therapy is evident through her years of service on the PT Utah State Board. She's served as nominating chair, public relations chair, and president of the Utah State Pelvic Health Special Interest Group. She currently represents Utah at the Academy of Pelvic Health through the American Physical Therapy Association. She's very busy and always helping to promote physical therapy and pelvic health therapy. So thank you, Katie, for taking the time to talk with us, and the floor is yours.
Thank you for inviting me to promote the world of pelvic health. I am beyond passionate about this topic and am very grateful to explain how this patient population can benefit from pelvic PT and how our interdisciplinary collaboration can go a long way in supporting patients' health. To begin, I do not have any financial disclosures or conflict of interest. My outline for today will start with kind of that viewpoint of PEN from a pelvic PT and where we can start. And that's where we need to begin with these patients. Kind of recognize do no harm. Then talk about the function of pelvic floor. Where is the pelvic floor dysfunctional? And then where are some options for interventions and things that we can do to support this patient? So PEM from the viewpoint of a pelvic floor PT, what can I do? What can I affect? Where can I see? In these patients who have experienced post-viral syndrome, we know as a physical therapist, we can support this idea of pacing, hormones, and multiple systems. We can support this idea of orthostatic stress. We can do our history in supine, and we can make these patients comfortable. We can put them supine. We can adapt our treatment. But one of the biggest things I want to advocate for is sensory. Think about the tone of our voice. Think about those lights. Think about the wall decor, the colors, the perfumes, the outfits that we wear. Are we wearing a very busy shirt? Are we coming into the room very dominating. How can we make these environments very comfortable to reduce stress and reduce overstimulation? Can we turn down the light on our computer? Can we make sure that the gym environment is not loud for these patients? What is their experience from checking in all the way through checking out, and thinking about our treatment as a whole experience, not just that moment that they're in front of us? Additionally, when we think about that physical stress, I really like to highlight this female hormone cycle. Hormones will impact patients' experience and where they're at in this cycle. Knowing that female hormone cycle is not always exactly 28 days. Some can be anywhere from 21 upwards of 40 if they're having regular cycles. And we know that some people do not, but their hormones depicted by these different colors may be fluctuating at different times. And so when a patient presents to you feeling great, and 7 days later they feel terrible, and then they feel great, understanding where and what hormone might be impacting them, I think was really powerful. And having this visual graph has been influential in my pelvic health journey when I talk to patients on why progesterone might be affecting them or estrogen might be affecting them, especially as we start to see some menopausal changes in women and estrogen deprivation. Or they might feel better when they're pregnant or not feel better when they're pregnant, and what might their body be experiencing. That's assuming all patients are born female. And we also understand that the male hormone cycle is also impacted with androgen deprivation that may start to experience in their 40s. And so we also want to think about our male assigned at birth patients as well. When we go through this PEM crash cycle, we also want to understand where are patients in that cycle, and also know that if we are seeing those early symptoms of flu-like, or they're having an IBS flare, cramping, or sexual dysfunction, or their pelvic symptoms are flaring, that might be my way to advocate to them that that's their body experiencing a symptomatic on their way into a crash cycle. And so sometimes I need to be that voice for them, that voice of reason, that as their symptoms are exacerbating, that they're on their way into a crash cycle, and that sometimes I need to pull back my intervention. We need to recognize that they're going to be on this roller coaster and that they're going to be going through these ups and downs. And we want to find a stable base first before we really push any kind of interventions. And patients, I think, sometimes don't recognize that their internal symptoms are an external exacerbation of what their body's going through. With that being said, moving into the function of the pelvic floor, I like to break this down into what I call the 5 S's. The pelvic floor is supportive. So supportive of the organs, supportive of the bones, supportive of the lower end of the body. It's also sphincteric. It seals the sewage. It holds things in at the right time. It's letting things out at the right time. We want those orifices to work accordingly. It's also designed for sexual function, so pleasure, arousal. It's designed for that stability of those osteokinematics. Also, we want to think of it as being a sup pump. We know that it is huge in the lymphatic and vascular systems. And so when I hear patients coming for pelvic PT, I want to kind of understand where in these 5 areas are they having symptoms, but then what can I also start to address? My priorities need to not necessarily be according to what I align with, but what did they align with? And what do they feel like they need to kind of address first, and then kind of break it down from there. When we think about the pelvic floor, it is a unique muscle, and this is where I get very, very nerdy. It does not have an antagonist. Biceps have triceps, quads have hamstrings. A lot of these muscles do not have an antagonist, so it is very closely related to the nervous system. It's innervated by the distal nerves. We have sphincters and we have so more of a closers, but we also have lifters. It's one of the few muscles that is purely anti-gravity, like the diaphragm. These muscles have elasticity that can change over time, but we also expect them to be under autonomic control. Most of us gain continence at 3, and so we don't think about these muscles, but they are very much affected by sarcopenia. It's very much affected by muscle wasting, but it's not a muscle we often train or pay attention to. It's also an area where a muscle attaches to a muscle. So that ATLA or that obturator internus muscle has an anchor point for a lot of other muscles anchoring to it. And so that can lead to its own dysfunction on its post-childbirth or post-trauma to this area for women, but it can also lead to some dysfunction. When we think about that pelvic floor in its own types of function, we think of it as those closers versus lifters. It has an anterior triangle and a posterior triangle. It has primary drivers and secondary drivers. So we expect this muscle to respond. So I want everybody just to try something for me now. Everybody do a deep cough. If your pelvic floor automatically responded, it should have had a vertical lift. A purpose of a cough is to expel air, expel sputum, expel something vertical. Now, try again. Did your pelvic floor go vertical? You had a normal functioning pelvic floor. If your pelvic floor went down, you had a load transfer, or what we would call a failed load transfer in the inferior direction, which can then cause downward pressure on organs, visceral tissues, vascular structures, and so forth. If somebody post-COVID had a chronic cough or were very ill with an upper respiratory dysfunction and had lots of repetitive impact and downward pressure on their pelvic floor, that can cause some muscle laxity, hypermobility, ligamentous stress, leading to a lot of other dysfunctions. And so we expect that muscle to automatically respond in the vertical direction. If we did that to bladder over and over again, we may develop stress incontinence and other dysfunctions. And so we need to understand why and where some of those dysfunctions are coming from to then know how to treat it. When we grade this muscle, I want to understand, is it strong? Is it have the right amount of endurance? Can it repeat that endurance? And can it do quick contractions? This is an endurance muscle. 70% of its fibers are meant to be working all the time. 30% are fast twitch. So when people talk about those quick twitch Kegels or quick twitch muscle activations, they're really only training 30% of their fibers. We need to be training those fibers over time. There's 2 gradings. There's the International Continence Society grading, which will say absence, trace, normal, or strong. Or there's the manual muscle testing grading, which is the physical therapy language, which is on the 1 through 5 scale. But we also want to think of this as endurance. How many seconds can it hold? How many repetitions can it hold? And then also those quick contractions. Depending on patient's dysfunctions, we need to train those muscle fibers correctly. That cough, that inner abdominal pressure test that I just had you do, is also a pass-fail test. And so those are all things that we as pelvic health therapists will evaluate. We can do this externally or internally, understanding that there can be failure in multiple levels. So layer 1, layer 2, or layer 3 of pelvic floor is all things that we assess. Intravaginally or intrarectally, depending on patient's anatomy, are things that we would look at as well. Additionally, these muscles don't hurt. Happy muscles don't hurt. And so as we evaluate these muscles, we also want to evaluate kind of resting tone, resting pliability if the patient is present. But we can also teach patients to do kind of a self-assessment and grade themselves if we ever had to do telehealth visits for these patients. This is assuming patients had normal functioning pelvic floor. But what happens in our patients post-viral syndromes or post-COVID? They have some dysfunctions. So what is the prevalence of some pelvic floor dysfunctions? In a meta-analysis of almost 25,000 charts, they defined pelvic floor dysfunction is including any type of urinary incontinence, pelvic organ prolapse, or bowel dysfunction, anal incontinence, or difficulty with defecation, including fecal smearing, and found that the prevalence rate is 1 in 3. This is in the normal patient population. And then patients with 2 or more diagnoses, the prevalence dropped to 5%. 3 or more was only 1%. Risk factors include being of Caucasian, having increased age, having a gastrointestinal disease, increased vaginal deliveries with increased instrument birth also increased your risk, and as well as obesity. A lot of these risk factors also align with some of our things that we see in COVID as well. In our patients with pelvic girdle pain, we also see a higher risk among our patients with EDS. So are we starting to see where a lot of these worlds can overlap? Patients who have had an infection or have had a traumatic birth or hypermobility, we saw that they had pelvic girdle dysfunction in at some point in their life at almost 88%. Pelvic girdle dysfunction can manifest anywhere along the pelvic girdle. I like to call this Grand Central Station. The pelvis, the tailbone, the sacrum, the ilium, the pubic bone, any of those specific areas can be considered pelvic girdle pain. The pubic symphysis is designed to widen 5 to 8 centimeters during delivery. And so as that pubic symphysis goes through a stretch injury and has some hypermobility, these load transfers and this dysfunction can become more prevalent. One of the things that I am finding really more fascinating is these pelvic venous insufficiencies, as well as some of this idea of some orthostatic intolerance and kind of POTS, as well as kind of this patient's sensitivity and fast heart rates in various positions. We understand that the function of the pelvis includes stability, but it also needs to give that pressure of these venous structures back up so it can supply that blood to the heart, to the brain. If these patients have had swelling or increased venous dysfunction, edema, varicosities, or they have compression syndromes in one of the muscular structures around their pelvis, it can cause some claudication or dysfunction that can contribute to contribute to their orthostatic symptoms, or contribute to their tachycardic syndromes, or contribute to POTS. And so when we think about this top down, I also like to think about this bottom up evaluation in some of these patients and what's going on in this pelvis that could be contributing to some of their symptoms. Some people do well with compression and some people do not do well with compressions. And this is where we have to think about what are their symptoms and how do they respond. Individual treatment is important. And their symptoms are what we need to consider. Additionally, when we think about pelvic floor dysfunction, I think we always kind of go to urinary incontinence first, but I think if we could also speak a more comprehensive language around urinary incontinence, I think this would help us describe pelvic floor dysfunction a little bit better, where we think of it as 5 different types of urinary dysfunction, with the 6th being a mixed. Stress. Stress is an event of failed transfer. So the bladder has stress put on it. Sneeze, cough, lift, laugh, bend, move. There's an action, the bladder has pressure, and then it leaks. Urge being a little bit more of an involuntary muscle contraction. I think of it as these kind of check-ins. How full am I? What am I sensing? Where this kind of detrusor movement. And it's like, hey, I'm getting full. It's time to go to the bathroom. And then I'm having a little bit of leakage. That can be irritant, failure of interoception, failure of feeling what my bladder is telling me. But additionally, we may have overflow. The bladder is too full. The bladder can't hold it. But also, if the patient's supine and all of a sudden they get into standing, there's a lot more inferior pressure on the pelvic floor, and then they may experience leakage. So if they were more supine, they were laying down, they didn't have a sensation, and all of a sudden they get standing, there may be a bladder capacity issue. With overflow, I may also argue that for some people who are fluid overloading and then they go into diuresis and then they're leaking, there may be a component of how we're drinking, and I'll bring that back up a little bit later. Additionally, neurogenic, we think a little bit about this communication to the spinal cord. We think a little bit about what's happening to the system. Is it communicating to the brain? What is happening? What's not depicted in this picture is functional. And functional is also with our patients who are maybe a little bit more bedbound. How long does it take to get out of bed? How long does it take to take off the pants? What is their hand dexterity? What is their distance to the bathroom? And how long does it take to get mobile and to transfer there? And what accommodations do they need? Those patients might do better with more of a bedside commode, and what's the level of energy that it takes to get to the bathroom before they're starting to experience leakage. Of course, mix can also be a combination of all of these. Typically, we think of incontinence affecting the bladder first, but these can also affect the bowels. Oftentimes, people instantly go to a weak pelvic floor, but a tight and tense and stressed and overactive pelvic floor puts upward pressure on the bladder and does not allow for bladder's capacity to stretch to its full capacity. And that may also contribute to some of these symptoms. So it's not just a matter of saying everybody's weak, do a Kegel, just like we don't say everyone has a headache, do tension or do upward shrugs of your shoulder. We need to really understand where is the dysfunction and what's dysfunctional, and then maybe how do we address it. Pelvic floor and MCAS. Oh man, I think I could spend all day really diving into maybe where some of these inflammatory diseases manifest in pelvic floor dysfunction. With the old nomenclature being kind of IC, we now are starting to be better about calling this painful bladder syndrome. And then the difference between IBS and IBD, irritable bowel syndrome and irritable bowel disease. I always like to tell my patients anything that is a syndrome is a compilation of things that have been ruled out and that we may experience symptoms at different times. Painful bladder syndrome is where people may experience urgency, they may ebb and flow. It's irritable. Their bladder can be symptomatic based off of something they've eaten. It may feel inflamed. It may be sensitive to their bowel movements. It can mimic pelvic pain. It can mimic muscle dysfunction. It often leads to multiple frequent urinations in the day. It isn't always relieved by emptying the urine. Just like with bowels, we may say irritable bowel syndrome, where they meet the Roman criteria, where irritable bowel disease, we have to have those clinical tests that confirm it. Both of these may experience pain, bloating, diarrhea, and urgency that isn't always relieved with emptying or evacuation. What I tell my patients with any of these inflammatory kind of symptoms is it can also be a volume experience, meaning that it's not always just a light switch. You get it one time and it instantly comes. It may be a level of exposure. So just like we can go out to the sun for 5 minutes and I don't get sunburn, but if I go out to the sun for 5 hours and then I definitely get sunburned, it might not be that you have that tomato in your sandwich and you get symptomatic. But if you have it in spaghetti sauce and you have it on pizza and then you have it again the next day, the volume may flare you. And so it needs to be more than just a one time, one episode. We need to think about this 36, 72 hours of compilation of where their body is maybe processing these foods, processing these things, and what are they experiencing. It typically will have patients zoom out 4 to 24 hours for bladder. I'll have them zoom out 36 to 72 hours at least for bowels and look kind of at their diaries over time to see where they're experiencing maybe some of these symptoms. With IBS and IBD, they can fluctuate between constipation and or loose stool. We can also have overflow diarrhea with the constipation still present. So the solid stool's there and the looser stool's kind of migrating around it. So both symptoms are present. With that, there's a lot of comorbidities that are associated with constipation. So chicken or the egg or the chicken, what comes first? We just know that both are present. With these post-viral syndromes as well, we know that the gut biome can also be greatly affected. And so habit, they may grab quick, easy foods. They may not be eating at all. The stomach is a muscle if it hasn't been working well. And so if they are experiencing some of these bowel disruption or some of these nauseas or some of these other comorbidities, sleep disturbances, and POTS and other symptoms, they may not be having normal food, normal hydration, normal things contributing to their body's function. This study that I quoted here is more in the younger population, but I do think a lot of constipation and a lot of habits learned are learned young. And so you are an N of one. Your bowel habits are your bowel habits. And so what you learn as a young adult often carry over. And so we don't sit around the dinner table. To my husband's dismay, I think this is normal to say, does everyone feel good? Does everyone have a bowel movement today? What was the consistency? Did it feel normal? Did you feel like you emptied all the way? But if we don't talk about it, these habits carry into our adulthood. And so we need to know that a lot of times these adult habits are carried over from our childhood too, and then can get worse after these viral syndromes. When we think about constipation as well, I do like to break it down into a couple of different styles. So lifestyle being one area, medication being another, transit being another, and evacuation being another. So we know lifestyle, hydration, nutrition, mobility, stress, those are all things that are low-lying fruit, low-lying things that often get addressed. But our patients are experiencing a lot of these challenges. They can't always process the fiber. They can't always have the same level of hydration that they once had, or they have a difficulty getting it in their system. They're not as active as they once were. Their body is going through physiological stress. So those lifestyle things are hard to address. Medically, we know they're going through a lot of chemical workups. Their electrolytes may be off. Their medications may be impacting them. Their age may impact things. If they're having hypothyroidism, vitamin D imbalances, all of those things may challenge them. But then also, certain nerve medications may also be affecting them. When we think about transit, we also need to understand is how long does it take to get to the exit? So is it a normal transit? Is it a slower transit? Is it getting stuck? Is it taking longer through a certain area? Is it slow and fast? That can all be disrupted by the nervous system. We cannot be in rest and digest and fight or flight. And so if there are some autonomic dysfunctions and dysregulation in this patient population, their bowels may be the first sign that we can pick up on, as well as we know that there can be an outlet dysfunction. This picture here shows the colorectal angle. So when we sit to defecate, the colorectal angle should elongate, it should open. But for some patients who have dyssynergia or a dysfunctional pelvic floor, their colorectal angle actually gets tighter, and that does not allow for the bowels to exit. So when their pelvic floor tightens, we want that puborectalis to pull towards the pubic bone, and that keeps things closed. For some people who have dyssynergia or discoordinated pelvic floor, their puborectalis pulls forward, but their external anal sphincter is trying to open, meaning that they're not getting through a diameter that's large enough to allow the stool to exit, where we want things to open and elongate. For some of our patients who maybe have a really lax pelvic floor, we might get the right colorectal angle, but they don't have the right inner abdominal pressure or core coordination to push the stool out as well. With the anal rectal manometry testing, that balloon testing can show some interesting challenges depending on the diameter of the balloon and how inflated the balloon is. And so some patients may test well if it's in a smaller diameter versus a larger diameter. But we also can then understand that the mechanics of when they get the first urge can be hypervigilant based off of having a foreign object in their rectum. And so I think a lot of times we're quick to do some of these dysenergic testings without quite understanding all the precursors that can go into the factors that contribute to their constipation as well. Additionally, I'm going to go back one other final thought. With that constipation, we also have to remember outlet obstruction could be there based off of hemorrhoidal and swollen tissues. Fibromyalgia, muscle myalgia, and pelvic floor dysfunction, there's a strong connection to the visceral structures and the somatic structures. These are the somatic convergence is a big thing that communicates to the brain. And we understand that this world overlaps and some hypersensitivity with central sensitization. Pelvic floor is innervated by S2, S3, and S4. And so when we think about those being those distal ends of the pelvic nerves, we know that they can pull on the bottom end of the spinal cord. They have pudendal intervention, parasympathetic, sympathetic intervention from L5. They communicate to the lower end of the rectum. They have motor intervention to levator ani. And so as we can think about tethered cord or that distal end of the spinal cord kind of pulling down on some of these patients with kind of CCI or other symptoms of migraine or headaches, we need to say, okay, do we want to go a top-down approach or a bottom-up approach? Sometimes getting those coccyx lobes, sacrums moving, bring up that sacral plexus can make a big intervention on mobility. We also understand that peripheral neuropathies can happen in the pelvic area, so decreased sensation, decreased awareness in the bowel and rectum. Those are all things that we should be thinking about and highlighting, whether it's peripheral neuropathies or something more autonomic. Just remember that these are patients that don't typically understand something's going on if we don't make them hypervigilant or make them aware of what's happening. These are also patients that do really well with some local muscle relaxers or some local diazepam, but I do want to advocate for patients who use vaginal or rectal suppositories or compounded creams that in patients with MCAS or tissue hypersensitivity, the compound that it is put in can be an irritant for people. And so I wouldn't always say a one and done, or if we use compounded estrogen cream, one and done. Sometimes the pharmacy, whatever they compound it in, we may need to experiment on a couple of different bases to see if they do better with a water-based gel. Do they do better with a glycerin? Do they do better with more of a suppository versus capsule versus liquid versus lubricant? So I do think sometimes we have to experiment with what's best for some of these patients to not only affect their tissues and also affect their nervous system. I recently came across this article about COVID-19 and the diaphragm in the pelvic floor, and I've been using this image from about the diaphragm from the Barral Institute and for years. And we know that the diaphragm and the pelvic floor are meant to have a synergistic relationship, and that's evidenced by the cough. Diaphragm goes one way, pelvic floor should go another. They should work together, just like the abdominals and the multifidi should go together. That's been studied for 30 years in physical therapy, if not more. And one of the things that we've understood is that in patients who have had a lot of coughing or chronic coughing, they've seen some changes in the mechanics to the diaphragms and mechanics to the pelvic floor. We've also seen that the SARS virus has also started to affect the ACE2 receptors, which affect the intestines, which also affect the bladder. And so when we think about those tissues being altered or having mechanical changes, I do think that there is a opportunity for education and recognition in this patient population. But then if the patients are apical breathers, they're upper breathers, they're neck breathers, and they're not using their diaphragm, they're probably not using their core, they're probably not using their pelvic floor. So even if you're an upper quadrant person and you're like, I'm only going to talk about head, neck, and jaw, the neck and the upper respiratory muscles are also probably being affected. So think about our patients COPD who are kind of chest breathers. Are they getting the full inhalation, chest wall mobility? What's going on with their pecs? But then also what's happening with those lower ribs? And can they cough effectively to clear whatever they need to? Interestingly enough, I've worked with patients who have had multiple years of pneumonia and ended up with COVID. We did some respiratory work, or we did some work around their respiratory system. We did some work around their pelvic floor. And so up to date, I still stay in contact with them. They've gone 4 years without getting pneumonia since treatment. So I think that's a pretty substantial thing to teach them how to cough and clear things pretty effectively and what we can do to impact patients' lives. Pelvic organ prolapse. There's lots of different types. I don't expect everyone to know the different types, whether it's bladder or a cystocele or uterine or rectocele or rectal prolapse or even hemorrhoidal prolapse. But if the patients are experiencing some heaviness, fullness with standing, maybe changes with positional, incomplete bowel movement, having to support the rectal wall to empty their bowel movements, these are all signs of prolapse. And working with our urogynecologist or urologist and or pelvic PT, I definitely think is something we want to be aware of. In our patients who are male at birth, there has been a retrospective study that found some of our men who got COVID were experiencing some higher rates of erectile dysfunction. And erectile dysfunction is closely linked to a lot of the psychological stress. We also know erectile dysfunction is linked to pulmonary function and cardiovascular health in cis men as we age. And so patients who with in this younger population in this study also found that they were having some of the similar symptoms we saw in the older men, but at younger onset. And so as we think about those cardiovascular changes that we may see in this post-COVID syndrome, microvascularization, we can also see those affecting the penile tissues as well. What do we do about some of these pelvic floor dysfunctions, or where do we go from here? Well, start with what you know. Start with this low-lying, start with the basics. I would like to say that we should be a low-risk, low-harm intervention, 5% better, 10% better, 15% better. We can make patients' lives better. We can advocate for modifications. We can advocate for improving their functional lives. We can advocate for modifications. We can be their cheerleader. We can start with some of this bowel motility with evacuation. We can start with understanding their pelvic pain, helping them give some predictable patterns, giving them some empowerment, recognizing some assist devices or compression garments, whether it's tank tops, whether it's leggings, whether it's lower extremity compression, whether it's some SI belts, whether we need to think about those surgical interventions in extreme cases. We understand this idea of pacing and really teaching people to just take one thing at a time. We can't address all of it. And I think we need to understand that sometimes these patients want to get better right now. It's going to take some time. And I think sometimes we have to be realistic with our patients, give them that empowerment to be okay with that. And then, of course, teaching them kind of orthostatic awareness. We are orthotherapists first. We are also neurotherapists, and then we specialize in the pelvic floor. And we need to remember we treat the whole person. Whether we do a top down and sometimes have to address their headaches or some of their upper symptoms first, or the bottom up, we need to make sure our symptoms align with the patient. Interventions can be education, it can be behavioral with diaries, lifestyle, understanding kind of their habits. We can then just do an activity diary. Sometimes just being understanding how much are they really doing in a day is helpful. Not just a bladder diary, but then also we can think about some of these neuromodulations that have been helpful in the pelvic. We can talk about kind of weight management if that's one of their alignments, but then also addressing their constipation. When I think about their behavioral habits, I really advocate for what I call the sip throughout the day, or not the flash flood method, evidenced by Saturday. We cannot handle when we get a lot of water really fast. Your body is very much the same way. When you give it a lot of liquid really fast, it cannot really absorb it. It needs to be 4 to 6 ounces at a time. It needs to be slow. It needs to absorb it. It needs to send it to those right tissues. If we give it 20 ounces at one time, it's going to kick it to the kidneys. It's going to send it to the bladder. It's going to give you those urinary urgencies. It's not going to be able to be utilized the way that it needs to. It has to be paced throughout the day. We talk about that from our motor mechanics. Why are we not talking about it with our food, with our water, with our other habits? So sometimes giving patients that ability to understand of what they're doing and how that may impact their bladder. Also, with these patients, when we're advocating for higher fluid volumes, put it into perspective. The bladder is a balloon. If the bladder holds 10 ounces and you're drinking 100 ounces a day, I expect you to void 10 times a day. That may feel excessive for somebody who wasn't used to doing that, but that's what I would consider is normal. And so then if they're feeling like they're having more urgency or more frequency, that may be within their new scope of normal. I also encourage eating more soups and like with vegetables or other ways of getting fluids in, and cutting back on maybe some of the crackers or breads or inflammatory foods that may not do well with them. I had a pediatric course that I went to. She took all these animal crackers and she took all these goldfish and she ground them up and says, "Does anybody want to eat this now?" And we all looked at her like, "No." And then she mixed it with some water and she's like, "How about now?" And we said, "No." It looked like paste, but then that's what we're putting in our body sometimes. And it was a really good visual to understand that, like, maybe are we not giving our body the nutrients that we need? When it comes to urge suppression, sometimes understanding that the detrusor is doing a check-in, we can give them some empowerment to their bladder habits. And then also making sure they feel like they can empty their bladder. We'll give them some techniques with that as well. Interventions, sometimes just preventing falls, teaching them some gentle movements that do well with their body. So some yoga-based techniques, skincare, skin irritation. These vulvar tissues are really sensitive to dyes and detergents. So how we wash our clothes, what clothes we wear, where are the seams of your underwear, can also impact the pelvic floor. There is a difference between lubricants and moisturizers. And so when we talk to patients about what are they using, what are they putting on their body, I think that's also helpful. There's a difference between urinary incontinence pads and menstruation pads and what are in those pads that can irritate those tissues. We'll also talk about sexual health and how that may impact the body and what your body feels post-sexual relations, as well as bowel habits. Being cognizant of time, I won't dive into a ton about transcutaneous versus percutaneous tibial nerve stimulators, but it does impact the nerve sensation. We can also do sacral nerve stimulator. There are some devices on the market like Ellatone that can impact bladder sensation. Essentially, they just stimulate the nerves. I think the big one that physical therapists can always be aware of is load transfer through the core. How does the diaphragm work? How does the lumbar spine work? How does the pelvic floor work? How does the core work? Additionally, how does the psoas work? Where are all these muscles kind of co-coordinating? The lumbar spine is independent of the hips. And so if the hips move, the pelvis should not move with it. If the lumbar spine moves, the pelvis should not move, or excuse me, the hips should not move with it. And so disarticulating those movement patterns is a big one for patients. Also understanding that we don't teach people to just do one type of pelvic floor activation. I also encourage everybody to not just go around saying, I'm doing my Kegels. We don't go around saying, did you do your Bulgarians today? If anybody knows what a Bulgarian squat is. Um, there's multiple types of pelvic floor activation. So there's just like there's multiple types of squats. We need to make sure we're targeting to the right tissues if we are loading them. But also we also have to think about quantity versus or quality versus quantity. And what is our intention? Are we going for urge or are we going for stress? And then also address muscle pain. There can be a lot of mimicking of sciatic and sciatica with pelvic floor dysfunction. Pelvic floor lives anterior to the sciatic nerve. And so a lot of times people will go after posterior musculatures for sciatic nerve dysfunction or posterior thigh pain. Remember, pelvic floor lives anterior to that sciatic nerve if you're having neural tension. A lot of vascular symptoms can mimic sciatic-like symptoms. And so Travell and Zinemans gives us some great understanding of some referral patterns, but then also thinking about these structures as they live together. If you can also incorporate this Cozen screening tool into your clinical practice, I think this would be very helpful. If a patient answers yes to 3 or more of these, they likely have some sort of pelvic floor dysfunction. This is a very easy way to ask some of these questions that maybe we don't feel comfortable asking about sexual discomfort or tailbone pain or urination. And so it's a very discreet way of saying, hey, these are your options that maybe are available to you. With that being said, I'm more than happy to advocate for my coworkers. There are a couple of ways that you can find us. You're welcome to email me through the university system. I'm happy to provide you with the Utah Pelvic Health list of providers that are here in the state. There are 2 national directories that a couple of different providers participate in. I know not everybody feels comfortable treating patients post-long COVID or post-viral syndromes. There are also multiple layers of training within pelvic health. And so there you would want to vet your local PT, but I hope that they can build a collaborative relationship with you. And we're a growing field, and we are more than happy to continue to work with our providers and learn from each other. We think interdisciplinary. I have my references in here, but I do want to open it up for questions. Thank you so much for taking the time to learn about pelvic floor dysfunction and normal functions and maybe what we have to offer to support this patient population.
Thank you, Katie. That was great. One of the questions we had is, are there resources you would recommend for nurses to learn more about pelvic floor? Well, it said physical therapy, but more specifically pelvic floor therapy that would be easy resources for nurses or other healthcare providers to access.
Yeah, the American Academy of Obstetrics has some resources. So ACOG has some resources. The International Continence has some resources on their website as well as APTA, Pelvic Health Academy has some resources. I think the best thing for nurses to first recognize is that we have a pelvic floor. I'm happy to start there. And then understand that it's integrated into a lot of these different systems. And so then if you suspect using that Cozen questionnaire tool and would a referral to pelvic floor PT be warranted would be the next thing I would advocate for. We
Great,
also
thank
have,
you.
I was going to say, we also have resources discussing it in the clinical practice guidelines through Bateman Horne, I believe, as well.
Great. You mentioned that with patients with post-exertional malaise or things, that often you have to make some accommodations to traditional therapy approaches. What would you say if someone had never heard about ME/CFS or long COVID or things, and they have a patient coming in with those diagnoses? How would you explain to them to quickly adjust their way of treating?
I think we always want to try to first fill our entire appointment time. But the first thing I have to recognize is you have to read the patient and understand that maybe my appointment time will be slower, or I won't get through all of my objectives and I will just put that in my plan. Additionally, if those were on my patient's kind of diagnosis list, I might need more interventions or breaks in my treatment. So I do an intervention, wait 3 to 5, maybe even upwards of 10 minutes. I might do more interventions that are supine. I oftentimes will also have to evaluate for real-time assessment. So I do one thing, wait for the symptoms. I watch the patients. If I start to notice a little bit of that flaring or the reddening in their neck, or sometimes the flushing of their face, or that kind of feeling dizzy, if I do an intervention in the abdominal or their pelvis and they're starting to say, I'm feeling dizzy or I'm feeling triggered, I have that two-way conversation of saying, I need you to tell me what your symptoms look like and how does that feel to you so that I can intervene sooner. And then I sometimes will have to then stop treatment and then just wait for that to pass. Or I let them kind of de-escalate until they can kind of adapt. Sometimes I have to cool the patient down if they're flushing. Sometimes I have to warm the patient up if they're getting really cold or getting really shivering or if they're feeling really tired. Sometimes I have to elevate the legs and take off some neural tension from the lower extremity, depending on what they're experiencing. And other times I have to kind of just tilt them up if they can't feel like they lay supine all the time. So it's a lot of mechanically moving my table based off of the positioning of the patient. I have one patient who does not do well laying supine. So all of my interventions are always relatively side lying. And that's one of the conversations that we say is if I lay supine for too long, I get dizzy. And so we have to adapt and lay side lying for half the time. And then we lay side lying for half the time. And we just have to accommodate based off of the patient's report. But I always start the conversation is today a good day? Is today a medium day? Or is today a bad day? And I need you to tell me what your symptoms are and when does it start to get bad. Leaving a little bit in reserve, knowing, again, it's a continuum of care. They're in front of me right here. They still have to get home. They still have to have other responsibilities. They still have to accommodate. So I want to make sure that I consider that other half of what they still need to do.
That's great. I think, yeah, checking for that post-exertional malaise after the fact is really important.
I will also ask patients to sometimes journal to me or message me, whether it's same day or next day or when they can. How did they recover 24 to 48 hours after? Because sometimes their symptoms don't always trigger in the session. Sometimes their symptoms trigger days after. And I need to know that long-term recovery. So of course, we don't ever mean to do harm, but sometimes they're like, oh, I felt great the first day and then I crashed. And I need to understand that after the crash component too, so that I think about that zoom out as well.
That's great. I have a question for some of our mentors, Dr. Bateman, Dr. Yellowman, Jennifer Bell. Uh, have you seen it helpful to refer to pelvic floor therapy, or what concerns do you have when you make a referral to a pelvic floor therapist? Yeah, Jennifer.
I have referred for pelvic floor therapy. I think my biggest concern um, is making sure that I refer to somebody who understands PEM. Um, because I have had patients go to other pelvic floor therapists and have a lot of worsening of symptoms because of the PEM. So your question, Clayton, was one that I had is how do you how can a PT adjust how they do their therapy and their expectations of therapy. I just have to remind patients they really have to be a self-advocate on pacing throughout their PT appointments and afterwards. But yes, and I've had some of my patients have definite improvement in some of their symptoms. So it's been I think it's a valuable tool for us.
probably ditto for me. I'm not sure I have much more to add on that. I think what I want is more pelvic floor therapists and more physical therapists who understand about the limitations of people with post-exertional malaise and orthostatic intolerance, because those things are so important when you're dealing with patients in a physical therapy setting.
Excellent. Thank you. What kind of options do patients have for attending physical therapy that's telehealth or in-home pelvic floor therapy?
This is where I really appreciate when patients can message me and they say, I'm not having a good day, and we will convert their appointment to telehealth. And then I say, okay, if we're getting to your window of tolerance, or hey, I'm only going to take us for XYZ because that's what's appropriate. Because I do think we need to accommodate the patient's tolerance level when they are having a bad day, but they still want some of this education. Learning to do some of these interventions for themselves. So self check-in, self breathing, self stretching, self kind of manual therapy, and or kind of symptom checking, I think can be really helpful. I appreciate having a table with my bed in the background, and then I'll move my camera and I kind of do things with them. But then also being able to do some of the heart rate regulation or some of the blood pressure regulation, I think is also a very helpful tool too.
All right. Well, that's super helpful. Thank you for sharing your expertise with us. Our next long COVID echo, long COVID and post infectious syndromes echo will be on November 4th at noon Mountain Time. And it will be with Dr. Melanie Hoppers presenting on pediatric and young adult care for long COVID. We will be sending out Katie's slide deck, and it will also be on YouTube. So look for that. And we're excited to have everybody join us next time. And please send any questions you have. You can send us an email, and we're happy to forward them to Katie. If you want to email Katie directly, I believe your email is on the slides as well. So thank you so much for joining, and we'll see you next time.